Moving forward, we invite on stage our chairpersons, Dr. Vinod Ravindran, he's the Director of Center for Rheumatology, Calicut, Kerala, and Adjunct Professor of Medicine at KMC Mahi, Manipal. Dr. Binoy Jepol, Professor of Medicine, KMCT Medical College and Consultant Rheumatologist, Bar Calicut, for chairing the next session. Now we request our chairpersons to kindly take over the session.
Good morning, everyone. So this second session, we got two jewels in the crown of not only Indian rheumatology, but also I think world rheumatology. So the first speaker is Dr. Padmanabha Shenoy, who is going to be talking on evaluation and management of CTD-PAH. Dr. Padmanabha is well known to this audience. He is the medical director and consultant rheumatologist at CARE, his own center at Kochi, and a host of achievements. But important thing I would like to mention is that his center is one of the very few in Kerala who has got a teaching program in rheumatology. So over to you, Dr. Shenoy.
Good morning. At the outset, let me thank both the chairperson for the kind words and Sukesh and the entire organizing team for organizing this wonderful conference and giving me the opportunity to talk on this complex topic. When a risk stratification and management of CTD-PH. So let us start with this index case of 45-year-old lady who had Raynaud's for 10 years. From the face itself, it is very clear what she has. She has scleroderma. She has mild breathlessness. That's what she used to say. HRCT was normal, and she had a mild TR with a right ventricular systolic pressure of 40. What do you do next? Before we go to what do we do next, pulmonary arterial hypertension is one of the major determinants of survival in CTD. So if you don't have pulmonary hypertension in scleroderma, your survival, 5-year survival is something around 80%. But the moment the pulmonary arterial hypertension sets in, the 5-year survival drops to 20 to 25%. So it is one of the major killers. And it is higher, the mortality rate is higher than many of the cancers. So we are talking about mortality. And if you see, unfortunately, this is data from US, the Wheel Registry, you can see most of the patients get diagnosed very late in the disease. 60% get diagnosed very late in the disease when they are functional class 3 and functional class 4, so we miss the bus early. So in this case, she has presented us pretty early with a very minimal right ventricular systolic pressure. We have an opportunity to save her life. The first question is, does she have pulmonary artery hypertension? We ask. When we get this echo report, PH undo, the answer, the question itself is bluntly wrong. Because, so first of all, we should not call it pulmonary arterial hypertension, we should call it pulmonary hypertension. Over time, what has happened is, the definition of pulmonary hypertension has changed. From 2015, it is always based on a measurement called mean pulmonary arterial pressure. So mean pulmonary arterial pressure, more than 25 was the initial definition, now it is 20. So mean pulmonary arterial pressure, more than 20, when a patient presents to you, you can diagnose them as pulmonary arterial hypertension. So can you calculate mean pulmonary arterial pressure by echo? The answer is no. We most of the time try to extrapolate. But what can we calculate? These are some cardiology concepts, but as a rheumatologist, if you are seeing pulmonary arterial hypertension, you need to know this. If you otherwise, it is very difficult to manage PAH. So you cannot calculate mean pulmonary arterial pressure by echo, but we can calculate something called TR jet velocity. Whenever you say an echo report, there will be a TR jet velocity which will be given there, and TR jet velocity, from TR jet velocity we can calculate right ventricular systolic pressure. And right systolic, from RVSP, we can calculate mean pulmonary arterial pressure. So what is the calculation? Mean pulmonary arterial pressure is equal to 0.61 into RVSP plus 2. For all of you, I have calculated this. This is if the RVSP is this is the mean pulmonary arterial pressure. So if the mean pulmonary arterial pressure, I told you the diagnosis cutoff is 20. For that, the RVSP cutoff is something around 30. But this is a surrogate marker. It is not an absolute marker, but this is a surrogate marker. So what RVSP should you take significant? 30 or more. But there are some other measurements which all of you should know. One is, there are three measurements actually. One is RA enlargement diameter, RA enlargement more than 18 centimeter square, TAPC. TAPC is nothing but tricuspid annular systolic excursion. That's called TAPC. It should be less than 18. Both values are 18. RA should be more than 18 and TAPC should be less than 18, and pericardial effusion. Why should you know this? These are very important markers for prognostication. TAPC, right atrial volume, and presence of pericardial effusion. In scleroderma, when you see pericardial effusion, we are worried about scleroderma renal crisis. No, it is a very good important prognostic marker for pulmonary hypertension. So our lady, as I told you, she had an RVSP of 41. So because she had RVSP of 41, from the chart you can very clearly see she has a mean pulmonary artery pressure of 27. 27 is mean pulmonary artery pressure. So can we diagnose her pulmonary hypertension? Can we diagnose? Can we diagnose echo to diagnose pulmonary hypertension? The answer is a big no. Can we use echo to predict probability of pulmonary hypertension? The answer is yes. You cannot diagnose, but you can predict that this patient has the probability of the pulmonary hypertension, yes. And another very useful marker is TR jet velocity. TR jet velocity is less than 2.8, you can reasonably exclude pulmonary hypertension, but if more than 3.4, you can probably say that this patient has pulmonary hypertension. Why TR jet velocity is important? As you know, RVSP we always calculate from the TR jet velocity. Can we assess severity of pulmonary hypertension by echo alone? The answer is again, so this is what always we used to do previously, which is wrong. If the patient has normal pulmonary artery pressure less than 20, mild pH 20 to 40, moderate pH 41 55, and severe pH more than 55. The cardiologist will always say this patient has moderate pH, severe pH. You cannot use. That's a very bad trend. We should never say that this patient has a severe pH based on mean pulmonary artery pressure or right ventricular systolic pressure. Can we use echo to stratify risk in pulmonary hypertension? The answer is again yes. But echo has its own limitation. Always remember, echo has its own limitations, and does not measure the pressure directly. TR jet is absent in 30 to 40%. There are lots and lots of why we should not use echo to diagnose or prognosticate pulmonary hypertension. But it can help in risk stratifying because it can measure the RA area. It can measure TAPC. It can measure pericardial effusion. So what we should never use is RVSP to prognosticate. What we should use is other parameters. So echo should be used to risk stratify and predict the probability of pulmonary hypertension. So how can we diagnose pulmonary hypertension? It is only by right heart cath. Right heart cath, when RA pressure is more, in right heart cath we can have lot of values, but most important value is mean pulmonary artery pressure and PCWP or pulmonary capillary wedge pressure. What does pulmonary capillary wedge pressure indicate? It indicates the left atrial pressure. Why is it important? I will tell you. So in this patient, as I told you, we had an RVSP by 41 on mean pulmonary artery pressure of 27 by echo. We did a right heart cath and she had a mean pulmonary artery pressure of 24. So what is the cutoff? 20, and she has 24. So we can diagnose her as definite pulmonary hypertension. So now what have we done? We have diagnosed this patient by right heart cath as pulmonary hypertension because she has a mean pulmonary artery pressure of 24. So what does pulmonary hypertension means? Pulmonary hypertension means there is hypertension anywhere in this circuit from subsegmental artery to left atrium. If there is a hypertension, we can say the patient has pulmonary hypertension. And the division comes between pre-capillary and post-capillary. I will tell you what it is. So this is the pulmonary circulation. So if you see here, this is the pulmonary artery which is getting divided into multiple branches. So group 1 pulmonary hypertension means there is a problem, increased resistance in the pulmonary artery. And if you have increased resistance only in the pulmonary artery because of primary pathology in the pulmonary artery, it is called pulmonary arterial hypertension or group 1 pulmonary hypertension. If there is a problem in the lung like CTD, ILD or COPD, then and secondary to that the pulmonary artery is getting affected, you have group 3 pulmonary hypertension. Group 3 pulmonary hypertension which is secondary to lung disease. But when this is thrombus or embolism, thromboembolism, CTEPH, it is called group 4 pulmonary hypertension or CTEPH. But if there is group 2 PH means there is a left heart disease, LV systolic or diastolic dysfunction which will lead on to the increased left atrial pressure and leading on to the back pressure. That is called post-capillary hypertension or pulmonary hypertension due to the secondary to left heart disease. The problem, it looks very simple. Oh, it's very easy to diagnose. The answer is, it's not that easy. If you see here, this is pre-capillary, this is post-capillary. You can see here, in scleroderma, you can have group 1 pulmonary hypertension, you can have group 4, you can have group 3, you can have group 2 also. Because you know scleroderma can affect lung, scleroderma can affect the left side of the heart, but it can also affect the pulmonary blood vessels also. So all this makes the things much more complicated. And we need to very clearly understand that in each patient can have a mix of these two too. But in lupus, but in scleroderma predominantly it is group 1, in lupus it is predominantly CTPH, and MCTD it is a combination of these three. So this is how the WHO classification comes. Group 1 is, I told you, idiopathic pulmonary hypertension. Group 2 is left heart disease. Group 3 is lung disease or hypoxia. Group 4 is CTPH, and group 5 is miscellaneous. So in our lady, and how to differentiate between these two, it is very simple. In group 2, you will have increased pulmonary artery wedge pressure and normal pulmonary vascular resistance. There won't be any pulmonary vascular resistance. Group 2, it is because left heart pressure is increasing, there is a back pressure coming to the right side. So the pulmonary vascular resistance will be normal and the pulmonary artery wedge pressure will be high. So if you, in our lady, we did a right heart cath, the pulmonary capillary wedge pressure was 12 millimeter and PVR was 4 Woods. So what does it indicate? There is no back pressure coming from the left side and the pulmonary vascular resistance is high. So, and CT was normal, so group 3 is excluded, and there was no pulmonary embolism, so group 4 is excluded. And finally, we have diagnosed her as group 1 pulmonary hypertension. Now she has CTD, now we can call her as CTD-PAH. So, group 1 pulmonary hypertension. Now what? So this is the beginning of the story. We have diagnosed her as CTD-PAH. Now we need to stratify risk. So, very simple. Stratification of risk is very simple. First and foremost important is functional class. You look at the WHO functional class. All of us know what WHO functional class is. Just to remind you, class 1 is normal. Class 2 is when they have climb stairs or do something heavy exertion. Class 3 is a normal household activity like bathing and etc. Class 4 is at rest. And this very simple tool which can be done in clinic gives a lot of information. 6-minute walk distance or 6-minute walk test. This gives the exercise capacity of these patients. Yeah, just keep a 30-meter distance and ask the patient to walk around. It is simple, inexpensive and extremely good with prognosis. But we don't do it in routine clinical practice, unfortunately. Threshold, less than 165 mortality risk and more than 440 meters is a predictor of survival. So if somebody has less than 160 meters, the 5-year survival is extremely bad. And what is other things which are important? 1 minute heart recovery and exercise-induced desaturation. The patient, ask the patient to walk for 6 minutes, look at their saturation. The saturation falls to 85, 80. It's a very bad prognostic marker. And see when does the heart rate recover. All these are of extremely good prognostic value. If you do it on a regular basis in a patient who has pulmonary hypertension, it gives lot of information. NT-proBNP is one of the biomarkers widely available. It reflects the right ventricular pressure overload and correlates extremely well with 6-minute walk distance, survival, and at baseline and follow-up. So we have, these are the 3 important tools. So ESC, ERS, REVEAL, there are multiple scores available, but I think for the simplicity's sake, we'll just stick to this score. ESC, European Society of Cardiology and European Respiratory Society, 4-strata risk assessment. This is the thing which has to be done at a baseline. There are only 5 parameters. One is clinical parameter, second is 6 minutes walk distance, third is biomarker, hemodynamics and imaging. So these are 5 parameters which are apart from the hemodynamics or right heart cath, everything else most of us keep doing day in and day out. It has to be done only at baseline. This is a 4-strata risk assessment. It has to be done only at baseline. Sorry, it's a 3 risk strata assessment. It has to be done at baseline. It classifies into 3 things: low risk, intermediate risk and high risk. So what are the things? I will spend 1 minute here. One is sign of right heart failure, very easy to do. Symptoms of progression, yes. So if there is based on this absent, present, we can have a different scoring system. Syncope, we can ask WHO functional class. All 4 parameters are very, very easy to ask. 6-minute walk distance, again very easy to do. Then NT-proBNP, all of us do, all of us have access. Echo, RA area, TAPC, pericardial effusion. This I told, always very, very important to look at the echo. Ask your cardiologist, they will give you these measurements. Probably cardiac MRI we don't do in a routine practice, and hemodynamics probably you don't have access if you don't do a right heart cath. The point I want to stress here is, only you need at least three variables. Getting three variables is very easy. Out of this, if you have any three variables, you can do the scoring. If you have ideally 4 to 6, and even if 4 to 6 is not difficult, all these 4 plus any of these 2, 6. 6 is not at all difficult. And based on that, we can divide, low risk is 1 point, intermediate risk is 2 point, and high risk is 3 point. Based on that, you can sum everything, divide by the parameters, and you will get a score. 1 to 1.5, 1.5 to 2.5, and 2.5 is high risk. So, we will do a baseline screening. And so this is done for the baseline. For the follow-up, you need to have 4-state approach. They have even made it even more simplified. Why I say simplified? Because you have WHO functional class, you have only 6-minute walk distance, and you have NT-proBNP. Based on these 3 parameters, you can very clearly stratify into low risk, intermediate low risk, intermediate high risk, and high risk. So some people think, why should I break my head doing all this? Answer is, it has been very, very clearly shown that if you treat the U-star cohort data from scleroderma data, very clearly you can see what is the mortality difference, 0.8 to 0.25. So 60% difference in mortality if you have high risk versus low risk. And between intermediate risk and low risk also there is a difference. This has been again shown in CTDPA, not only in this, very clearly people have shown in different big cohorts that if you stratify, you can clearly look at the mortality in long term. So, now I told you how to stratify. We have diagnosed, we have learned how to stratify. Let us see what should be the goal of treatment is aim to achieve low risk profile. So, less than 5% or a score of less than 1.5 is the goal. Low risk is defined as any one of 2. Very easy. WHO functional class 1 or 2, 6-minute walk distance more than 40 millimeter, and NT-proBNP normal. Even if we have these 2, that is good enough. And if you have, and it has to be assessed every 3 to 6 monthly. So finally, we have diagnosed, we have learned how to risk stratify. Let us see what are the treatments available. Pulmonary hypertension has seen lot of therapies which are over last 10-15 years. I still remember scleroderma PH in 2007-8 was a death sentence. From that we have moved on, and in India we have access to all these therapies now. There are 2 basic pathways which we have access to. One is nitric oxide pathway. Nitric oxide pathway is targeted by a phosphodiesterase inhibitor like sildenafil and tadalafil, and riociguat is a guanylyl cyclase inhibitor. All these 3 molecules are available in India, and also endothelin receptor antagonist, ambrisentan, bosentan, and macitentan. And also now with selexipag, which is a guanylyl cyclase inhibitor, it is also available in our country. So we have all the molecules accessible. I have just summarized all the clinical trials for all these molecules: bosentan, BRIT1, ambrisentan, ARES 1 and 2, macitentan, serafin, sildenafil, super 1, etc., etc., etc. The point is, you can see here most of them improved 6-minute walk distance. In Griffon trial, which is a selexipag trial which was published recently, again showed that there is a mortality benefit. Also in macitentan trial showed that there is mortality benefits. We are not talking about erosions, we are not talking about deformities, we are thinking about death. So this, and also ambrisentan tadalafil combination, this is one of the LARMAT trials which is called Ambition trial, very clearly showed that ambrisentan and tadalafil reduces the clinical failure when compared to monotherapy. So look at the difference. Ambition trial, this is the mortality benefit, combination versus pooled monotherapy, around 20% difference. Griffon is with selexipag, again 15 to 20% difference. This is the latest trial which was published, triple therapy, tadalafil, macitentan and selexipag versus dual therapy, around 15 to 20% difference in mortality at the end of 2 to 3 years. So these drugs improve survival, they improve patient survival is beyond doubt. And combination is the rule, not the monotherapy. So this is again, you can see here, this is a recent study which was published. What they do, if you see here, this is I told you the initial chart. The patient is not treated with pulmonary hypertension, the mortality is around 40% at the end of, 40 to 50% at the end of 3 years, and 20% at the end of 5 years. If you give usual care means most of us used to do what we used to do in 2020 or 2019. Just start patient on tadalafil, keep doing an echo, don't risk stratify, don't up titrate. The patient will do relatively better. The survival get improved to 3-year survival of 50%. But you give goal-directed therapy, the survival improves even to 80%. Much better therapy. How should you do? I told you already, risk stratify every 3 monthly. So there is a definite improvement, and it is a mortality benefit. It is not about improvement quality of life. You prevent deaths, and not to a small extent. 20 to 30% increase in 5-year survival is really, really huge. So goal-oriented combination with a, what is goal? WHO functional class 1 or 2, 6-minute walk distance more than 400 and NT-proBNP less than 300. Then came this remarkable molecule. This was, I am sure most of you must have heard about this, sotatercept. Sotatercept is basically first disease-modifying therapy in pulmonary hypertension. Till now we were speaking about what? Vasodilatation, improved dilated blood vessel. But here it is doing something very fundamental. It is activin signaling inhibitor, so it is modifying the blood vessels in the lung or the pulmonary artery. And this sotatercept, you can see the survival curves. There are 3-4 stellar trial. This is called Zenith trial, which was published last. You can see the 2-year survival, 3-year survival, almost 85 to 90%. Vis-a-vis placebo, 20%. So indicate, and these patients were on triple therapy. Most of them were on selexipag, macitentan and tadalafil. So very beautiful drug which improved the survival of pulmonary hypertension patient to a great, great extent. I think this is going to be a game changer in the management of pulmonary hypertension. And fortunately, this is going to get launched in India next month. But unfortunately, the cost of therapy is very high. So I have been speaking to them to give, because we have 3 or 4 patients who needs this. So they have told that they will give some patient assistance program. But this is going to come in our market in Jan or Feb, and a lot of lives it can save. So I have told you what are the drugs available. I have told you how to diagnose and stratify. So how to assess in a day-to-day practice. So you have diagnosed, though, how do you do first? High risk or not high risk? In the baseline, we are not bothered about intermediate risk. Whether if the patient has high risk, you start a combination of guanylyl cyclic, you start on selexipag, tadalafil, macitentan. If the patient is not high risk, you start on tadalafil and ambrisentan or macitentan. So let us see in a practical case what we do. In this case, she had a class 1 pulmonary hypertension, or class 1 PH or CTD PH. I told you we had done a right heart cath. What should we do now? This is an online tool. I have scored here. Look at this. Most of the things, she doesn't have any signs of heart failure. She doesn't have syncope. She is functional class 1 or 2. 6-minute walk distance is 400, more than 450 meters. So her score is at 1.4 because her NT-proBNP is also slightly high, and RA area and all I have scored here. The score is 1.4. It is very easily available online. You can just go and click. 30 seconds it will take. So she is not a high risk. So she is a low risk. So I started on phosphodiesterase inhibitor and tadalafil and ambrisentan. She did reasonably well. What happened was 2 years, and her 6-minute distance was, she was walking well. She defaulted on follow-up for 1 year. She didn't come back. According to her, she was taking drug. When she came back to 2024, she comes back for follow-up. She has breathlessness. She is telling, now I am not able to climb stairs slightly. My breathlessness has increased. So functional class 1. I looked at the NT-proBNP. NT-proBNP is 1000, and 6-minute walk distance has significantly decreased from 500 to 200. So unless you do these two, you are going to miss the bus. Then for follow-up, I told you we should do for this strata ESC. Again, very simple. Go online, just score this. So functional class 1 and 2, her 200 meters, NT-proBNP is high. So she is now moved to intermediate low risk. So intermediate low risk means we need to up-titrate. What do you up-titrate? Basically, from tadalafil ambrisentan, we can add selexipag. Third drug we have to add. But unfortunately, after 6 months, she is progressing. She became functional class 1 to functional class 3. NT-proBNP increased, and WHO functional class, 6-minute walk distance came down to 175, and NT-proBNP is sky high. So she became intermediate to high risk, or it comes here. So once that happens, ideally she needs sotatercept, because she is otherwise her 5-year survival is going to be really bad. Even 2-year, 3-year survival is going to be 20% or 30%. So, but she is not affording at the moment. So I am continuing on selexipag and other measures. But ideally, if sotatercept is available at an affordable cost, I think I will consider that. So, what about immunosuppression? There is a reason. Immunosuppression is scleroderma, pulmonary hypertension. People used to say we should not, because there is not much evidence. This is one study which is available, which has shown that rituximab improves the 6-minute walk distance, and there is less requirement of new medication, addition of new vasodilators. So, but it's very, very early data. But there is MCTD and lupus. We all of us know that CTD, if it's MCTD or lupus, immunosuppression has a huge role, and most of the patients do extremely well in long term. So MCTD, lupus, pulmonary hypertension, immunosuppress. Scleroderma, there is a very less evidence. Last question. If somebody has group 1 pulmonary hypertension, group 3 pulmonary hypertension, what is group 3 pulmonary hypertension? Group 3 pulmonary hypertension is somebody who has a lung disease. For scleroderma, people have lung disease. On top of that, they will have pulmonary hypertension. What I want to say is, always you should treat only when there is a severe pulmonary hypertension. What is severity? Mean pulmonary artery pressure more than 35, and there is a hypoxia. If the patient has severe pulmonary hypertension along with interstitial lung disease, tadalafil may be useful, but you should never give ambrisentan or macitentan because it is known to worsen the lung disease. And if it's a non-severe pulmonary hypertension, what you should do? You keep treating interstitial lung disease, that with mycophenolate or tadalafil, rituximab or etc. So what is the take-home message? 1. Suspect by echocardiography. Pulmonary hypertension, suspect by echocardiography. Second, always do right heart cath. A very simple tool, very inexpensive. It's not very expensive. 15,000-20,000 it will cost, but it will give you a lot of information. Stratify it baseline. Even if you don't do right heart cath, I am okay. But do stratify. For ES has made it very, very simple. Start on goal-oriented combination therapy. You give tadalafil, you give ambrisentan, it's available. If the patient, and reassess at 3 to 6 months. Again, do a scoring system. Readjust therapy, add other therapies which are available. And by doing this, we are preventing mortality. And please remember, when we are treating with CTD pulmonary hypertension or CTD PH or any PH, we are playing with death. And we need to spend 2 to 3 minutes to assess whether our patient is in low risk or high risk, or what kind of death, what kind of risk of death they are facing. We do 5 minutes DAS28 score, but let us frankly look at ourselves and think how many of us are really risk stratifying CTD PH. And if we are not doing that, probably we are not doing justice to our patients because they are going to die in front of our eyes. Thank you for patient listening.
Thank you, Dr. Shena, for the excellent talk, as usual.
Thank you, sir.
Doing a right heart cath is difficult. Many of our cardiologists are not very happy to do it. So any other methods?
Sir, that's what I told. See, when should we do right heart cath? Ideally, I said right heart cath has to be done for everybody, but somebody comes to you with a mean pulmonary artery pressure, so you have an RVSP of 60, 70, you very clearly know that they have pulmonary hypertension. In those cases, probably we can get away. In early cases, right heart has to be done because otherwise we land up over-treating. But right heart cath, actually the cardiologist, if you request them, pediatric cardiologists are the one who are very happy to do it. For us, Joe's wife is there, so she does for us. It's not very difficult. Patients are also very comfortable doing it, and the cost is around 10 to 15,000. Probably these people are not, some people are not interested because it is a difficult procedure. It takes more time than their coronary angio. That may be the reason. But it's not very difficult procedure, sir.
Yeah, Dr. Shenoy, very good talk. Thank you very much. We cannot but fail to notice that in terms of monitoring the disease aspects, there is no role for right heart catheterization.
No.
So does that seem a bit odd, because that is the most accurate sort of way of knowing what exactly is the pressure?
So the issue is, doing a repeat right heart cath, one is difficult. Second, mean pulmonary artery pressure alone is not going to predict your mortality. Mortality is predicted by NT, for follow-up is NT-proBNP, 6-minute walk distance and functional class. So all the risk models are very clearly shown that even if you don't have echo, that is fine. For follow-up, echo is also not required. Echo has to be done when you change therapy, or look at whether the RV is failing, whether the RA is getting dilated, those or pericardial effusion appearing. Probably that is the time. If you change a therapy, within 3 to 6 months, you do an echo. That's enough. Sorry.
Any questions from the floor?
I've been using Ambricam. One lady is there. She has a severe pulmonary hypertension, but not your rheumatology, not related to SLE or something. But what happened is she has recently developed severe anemia because of Ambricam and eating of feet. So what do? You stop the medicine, Ambricam at that time? Because I
have-
have given blood transfusion, I have just discharged her.
Basically,
But,
we have to change to macitentan or try other therapy and add tadalafil or selexipag or riociguat. Other drugs are there. We have to change. So if severe anemia, yes, or severe pedal, but practically we have 200, 300 patients. I don't think a lot of our patients has developed the severe anemia.
this patient I just recently.
Whether some other causes are there, we need to see, sir.
The other thing is about the dose of tadalafil. Most of the time we are not using the proper dose.
Yeah,
They just give us a prasadam dose of 20 mg and all this.
Very true. We have to give, so I have shown the dose also in one of the pictures. So 30 to 40 milligram has to be given and ambrisentan of 10 milligram. But what is most important, I think, is to risk stratify these people and adjust the therapies every 3 to 6 months. What we do like DAS28 or CDI. We keep religiously doing that. Probably these are recent stuff and it gets to be, we need to get adapted to this to our practice on a day in, day out.
There is some change in the schedule of this program because of the inauguration and the oration. We'll continue after this session.
We shall now resume the early scientific session. As announced, the postponed topic IgG for disease will now be presented. May I now invite Dr. Vinod Ravindran and Dr. Binoy J. Paul to kindly come forward and take the chair. And we request our chairperson to kindly introduce the speaker.
The next topic is IgG4 disease, and the speaker is none other than Dr. Vishad Vishwanath, Secretary of IRA Kerala chapter, who is well known to all of you. Dr. Vishad, please.
Thank you, sir. So, I'm talking about IgG4 related disease, and I've been asked to discuss in the light of the perspective of it being a great masquerader. So what does IgG4 mean? IgG4 is actually an antibody. It is in fact a unique subclass of immunoglobulin G with anti-inflammatory properties. So we know that there is IgG, IgE, IgD, and IgM antibodies. So IgG again is subclass into IgG 1, 2, 3, and 4. And this is IgG4 is the least abundant of all IgG subclass, contributing to just about 3 to 6% of the total IgG. Usual IgG antibodies are, they enhance complement activation and they are pro-inflammatory, and they also facilitate the Fc receptor binding and antigen recognition, triggering immune response. However, contrary to the usual IgG function, IgG4 antibodies are poor activators of complement, and they have a weak Fc receptor binding. They actually are markers of immune tolerance and chronic antigen exposures. So there is an antigen to which you are exposed to, but the body learns to tolerate it without mounting any significant immune response, and this is a marker of such an immune response. And it's an antibody which is fairly elevated in patients with allergy desensitization and chronic inflammation, and along with IgE. It reflects immune, in fact, the presence of IgG4 reflects immune dysregulation rather than autoimmunity. So this is what IgG4 antibody looks like. So it has two arms, but the FAB arms have two valencies, at least two binding sites for antigens. This has only one binding site, making it less effective for complement fixation as well as less readily recognized by the Fc gamma receptor. The FAB portion of the Fc portion of this antibody is also has a less affinity for binding with the Fc gamma receptor. So you know that the antibodies have FAB and Fc portion. FAB binds with the antigen and the Fc portion binds with the receptors on the antigen presenting cell. So the FAB has only one valency, so that becomes less immunogenic, that's less capable of binding to antigen, or they bind to antigen with less affinity. The Fc portion also has a less affinity for the Fc gamma receptor, so they do not trigger the Fc gamma receptors as the other immunoglobulins do, and there is less activation of the antigen present, the downstream activation of the Fc gamma receptor functions. So before IgG4 related disease, in fact, back in 2001, 2022, when we were reading our surgical textbooks surgical textbooks, we used to read about these conditions: Reader's thyroiditis, retroperitoneal fibrosis, Mikulicz disease. So these were all considered to be fibroinflammatory disease, but considered fibroinflammatory disease of different spectrum. Then there used to be other inflammatory pseudotumors, sclerosing cholangitis, etc. And these used to be fairly often misdiagnosed as malignancy, tuberculosis, or even idiopathic fibrosis. And some of these were noted to have steroid responsiveness, but as I mentioned, there was no unifying concept. In late 90s to 2000, the Japanese studies on autoimmune pancreatitis, this was the condition where the disease was first recognized, and they found that a subset of patients with pancreatitis had steroid responsive pancreatitis with some forms of systemic involvement. And they were also noted to have elevated serum IgG4 levels. And what's more, the histopathology from these patients showed that there was abundance of IgG4 antibody positive plasma cells. Plasma cell, you know, is the cell which produces the immunoglobulin G. And IgG4 was, and hence there was a recognition that IgG4 could be a key marker for this potentially new sort of disease. And from 2003 to 2011, progressively papers came out, and it was known that IgG4 rich disease, there could be a subset of IgG4 disease which could be affecting a single organ or multiple organ, and commonly these used to involve organs like pancreas, salivary glands, bile ducts, kidneys, retroperitoneum, and aorta. The common histopathologic features of these diseases was that there used to be profuse lymphoplasmacytic infiltrate. There used to be what is known as storiform fibrosis. That is, the fibrosis used to be in the shape of, the fibroblast would be in the shape of walled arrangement of the flowers, and obliterative phlebitis. That is but the veins inside the tissue would be obliterated by inflammation. However, it was subsequently realized that all these findings may not be there in all cases. And so from 2010 to 2019, this disease came to be recognized as a unique entity of in systemic immune-mediated fibro-inflammatory disease. And subsequently there were many criteria for diagnosis of the disease. However, what was noticed quite early in the recognition of this disease was that the elevated IgG4 levels was not specific to IgG4-related disease. In fact, IgG4 levels could be elevated in conditions like rheumatoid arthritis, SLE, ANCA vasculitis, particularly ANCA vasculitis, because they can also have fibroinflammatory manifestations, and they can also have high IgG4 levels, particularly as part of polyclonal hypergammaglobulinemia and inflammatory bowel disease. Then, as mentioned, atopic and allergic conditions can have high IgG4 levels. Chronic infections like tuberculosis, parasitic infections also, probably as part of, because these are chronic infections and the body is trying to mount a tolerance to these infections without mounting a significant immune response. So possibly they are having elevated IgG4 level as a consequence of that. Then, of course, as would be expected of any condition where an immunoglobulin, any particular subtype of immunoglobulin clonal immunoglobulin level could be increased, malignancy and immune dysregulations are also causes. Then in 5 to 10% of healthy individuals also, the IgG4 levels are found to be elevated compared to the peers. So in order to strongly suspect for an IgG4 level, IgG4 disease, the levels are considered to be usually more than 135 milligram per deciliter. Some labs have a cutoff of, some criteria have a cutoff of more than 2 upper limit of normal, more than 2 times upper limit of normal, or even 4 times upper limit of normal. But the higher the levels are, the chance of the disease being there is also highest. So we have a ACR/EULAR 2019 classification criteria, as well as a 2020 Japanese revised comprehensive diagnostic criteria for diagnosis of IgG4 related disease. So in the ACR/EULAR classification criteria, you have an entry criteria where there has to be a clinical or radiological involvement in an organ that is typically likely to have an IgG4 related disease. These organs, as we have mentioned, include pancreas, salivary glands, bile ducts, orbits, kidney, lung, aorta, retroperitoneum, and pachymeninges. So in these organs, if you have a manifestation that could reflect a IgG4 related disease like a fibrosis or proliferative tumor-like lesions, with a typical radiological involvement, that would be entry criteria. That would be when you are suspecting this disease. Then, of course, there are exclusion criteria, because classically this disease does not have much of extraneous inflammatory responses like fever, weight loss. So these would be oddities, and absence of response to steroids, serological features such as presence of autoantibodies, imaging showing rapid progression. This is a very indolent disease which probably develops over years together. Pathological features such as presence of malignant cells, neutrophils, granulomas, necrosis naturally. Then, of course, when you have the entry criteria and exclusion criteria, you also have the inclusion criteria, where you have the typical histopathology, high IgG4 levels, and the typical involvement in the imaging studies. So these would actually contribute to a perfect diagnosis, classification of a condition as a IgG4 related disease. The revised, mind you, this is a classification criteria which is mainly for studies, comparison for studies across centers, and diagnostic criteria is more for specific diagnosis to that particular condition, and you have a diagnostic criteria which was mooted out by the Japanese. So again, these also want a clinical and radiological features suggestive of IgG4 related disease in the form of a localized swelling, diffuse swelling, or a mass or a nodule. That's a prerequisite. Then in those patients, they can have a serological diagnosis where a serum level of IgG4 levels more than 135 milligram per deciliter would be there. Pathological diagnosis where 2 out of the 3 criteria, as I mentioned, dense lymphoplasmacytic infiltration with fibrosis, ratio of another important aspect is the ratio of IgG4 positive plasma cells to IgG cells. Typically, these are more than 40% in a biopsy specimen, or more than 10 IgG4 positive plasma cells in a high power field. Or if it's a completely resected specimen, the IgG4 ratio, some experts say that has to be more than, if it's a completely resected out specimen, not just a biopsy specimen, they would suggest that more than 70% is required. And then typical fibrosis, particularly styrofoam fibrosis or obliterative phlebitis. So all patients will not have all the criteria fitting. So what they have suggested is that if you have everything well and good, then you can definitely diagnose. If you have 1 and 3 alone, then that's a probable diagnosis, and if it's 1 and 2 alone, that's a possible diagnosis of IgG4 related disease. So basically, I think the point here is that the clinical and radiological features should be fitting. So you have a diffusely infiltrating condition or a tumefactive condition, and an organ which is susceptible for developing IgG4 related disease, along with a serology which is suggestive, along with a pathology which is suggestive. So if you have a combination of this, you need to think about this condition. So I'll just discuss 2-3 cases which have really which will take us through the journey of diagnosing an IgG4 related disease. So this is a 64-year-old lady. She presented to me about 6 months back with periorbital swelling of both eyes, and she had also mechanical pain of both knee joints and low back for 7 years. Had a dengue fever in November 2024. Actually, she came to me in December 2024. She didn't have any systemic symptoms. She was a diabetic for 7 years and hypertensive for 2 years. So mind you, she did not have any systemic symptoms. This is the patient. She had periorbital swelling because the clinical features would be masked, so I can mask the face of the patient. So she had very evident periorbital swelling. She had a fullness in the parotid and submandibular region, and she had clinically palpable large size cervical lymph nodes all through the different subgroups in the neck. And however, rest of the systemic examination was normal. And because she had a parotid, possible lacrimal swelling with a parotid swelling, we did a Schirmer's and USWSF, both were normal. My first instinct, and this patient had brought some, and we did some baseline investigation, which showed a low normal total count. ESR was high, it was 98. Total protein was markedly elevated, 10.3. Albumin was 3.8, and there was marked hypergammaglobulinemia. So my first instinct when I saw this patient was that she has so many lymph nodes. So particularly in our place, what happens is that a biopsy, when we suspect a malignancy and we do a biopsy from one center, a center which is dealing with the malignancy would not usually accept it. They would usually ask for a repeat biopsy. So what I thought is that I had a high index of suspicion of this being a lymphoma. In fact, everything fitted towards a lymphoma. So I referred the patient to a oncologist for their evaluation. So they did a cervical lymph node biopsy which showed chronic CL adenitis, echo was normal, and subsequently, PET scan was done subsequently, I'm sorry. So in this case, clinical diagnosis, first, second, and third diagnosis would be a lymphoma, and other conditions that we would think of would be to sarcoidosis, tuberculosis, and maybe IgG4 related disease, and we referred to the oncology side. So they did a PET scan which actually confirmed the presence of multiple enlarged nodes, not just in the neck area, but extensively all throughout the submental, submandibular, axillary, mediastinal, and retroperitoneal nodes. However, they were low metabolically active, and histopathology was also subsequently done from this. So these were the lymph nodes which showed a good uptake in the PET scan, extensive lymphadenopathy. And they did a biopsy which actually came out as, they said that the biopsy was reported as not having any evidence of lymphoma. So now that lymphoma was ruled out, so biopsy showed dense plasmacytic infiltrate, no histiocyte infiltration, no atypical cells, and CD68 was negative. So lymphoma was ruled out. We are thinking of suspicion, possible diagnosis of Mikulicz disease, sarcoidosis, Jogren's disease, and the other condition that was considered now was Rosset-Dorfman disease. Because these are conditions which actually can present with cervical lymphadenopathy, they can present with glandular enlargement, lacrimal gland or the submandibular gland enlargement, and some of these conditions can have dense plasmacytic infiltration. Rosset-Dorfman, I'll come to that later. And we did the further workup. So hemoglobin was 12, ESR was 123, AC level was elevated actually, but you see the IgG4 level, there was marked elevation of IgG4 level, in fact 35 times upper limit of the normal for that particular lab. We did the other autoantibodies, and these antibodies were negative. ANA was 1+ positive, but profile was negative. So on the same histopathology specimen, this patient by this time had come back to us, and on the same histopathology specimen, we asked them to do a immunohistochemistry for IgG4. And this is the report. There was more than 75% positive staining for IgG4, confirming a diagnosis of IgG4 related disease. So this patient had multiple cervical lymphadenopathy, glandular swelling, high ESR, no systemic symptoms. Mind you, no systemic symptoms at all. And biopsy showing lymphoplasmacytic infiltrate, not really storiform fibrous or phlebitis, but there was a very strong positive staining for IgG4 cells. And a close differential diagnosis that we need to consider in this condition, where a patient can present with the submandibular Mikulicz-like presentation, is a Rosset-Dorfman disease. This is a non-Langerhans cell histiocytosis, also known as sinus histiocytosis with massive lymphadenopathy. In fact, I have had one patient whom I diagnosed initially as IgG4, but then subsequently turned out to be Rosset-Dorfman. That's why I thought I'll put this as a differential. Typical presentation is a painful, massive cervical lymphadenopathy with glandular infiltration as in this patient. Fever, weight loss, raised DSR, and polyclonal hypergammaglobulinemia may be there. Especially as part of this hypergammaglobulinemia, there may be very high IgG4 levels also. And similar to IgG4 related disease, this disease can involve the skin, orbit, CNS, bone, and upper airway. And the diagnosis is by a biopsy, and which could show a CD66 positive macrophages, abundance of CD66 positive macrophages, and management is often a self-limited condition which might require some steroids and immunosuppression, and usually responds well to it. So in this case, to summarize, the clues to diagnosis was the presence of salivary gland involvement, lacrimal gland involvement, and lymphadenopathy, absence of systemic symptoms, and mind you, this patient had normal CRP, which I failed to highlight, exclusion of other diseases. Other possible findings that could have been there in this patient is eosinophilia could be there in a subset of patient with IgG4 related disease, high Ig levels. The reason why eosinophilia and high Ig levels happen is because IgG4 is actually a product of what we know that T cell activation can occur at two levels. One is what is known as a TH1. In fact, at multiple levels. One is the classical one is TH1, TH2, then T regulator and TH17 is the classical teaching. The IgG4 related disease is something which is driven by the TH2 arm of the adaptive immunity. And this is the typical presentation of this TH2 arm is high IgE levels and eosinophilia. The second is a 68-year-old gentleman who was referred from a tertiary hospital with a history of lower abdominal pain. He had been previously seen by a urologist and was diagnosed to have retroperitoneal fibrosis, and he was being planned for stenting. This patient had no other systemic symptoms but had some weight loss. And this is the summary of investigation. This patient had a hemoglobin of 11.3, I'm sorry, it's not 1 point, it's 11.3, mild normochromic normocytic anemia, ESR of 106, CRP of 12.5, a normal CRP is less than 6 in the lab. Renal and metabolic parameters showed normal electrolytes. Creatinine was 1.66, which was mildly elevated. And this was the report that he carried. So this was a MR iotogram which showed an irregular mass which was encasing in the paraortic region, which encased the aorta up to the iliac bifurcation, and the lesion also encased the inferior vena cava. It extended to the renal arteries and inferior mesenteric arteries, and it was also pushing the ureters to one side, and there was mild hydroureteronephrosis. The ureters were also encased by this paraortic mass, and there was ureteric compression. So basically this is a case of retroperitoneal fibrosis with peri-aortitis. The aorta is involved and there is fibrosis in the retroperitoneum. So what are the causes of this manifestation, this kind of clinical picture? One of them that has been recognized is that IgG4 related disease is a classical condition which can cause retroperitoneal fibrosis and periaortitis. The other conditions include malignancies such as lymphoma, prostate, colon, breast and stomach, which can metastasis to the retroperitoneum. And then there can be retroperitoneal tumors, primary retroperitoneal tumors, which may mimic this presentation. Drugs such as beta blockers and methotrexate were classically considered to cause this condition, but they are probably very rare. Infections such as tuberculosis and fungus, post-radiation phenomena can also cause this. Autoimmune conditions, as I mentioned, similar to in case of the first case, ANCA vasculitis, autoimmune sarcoidosis, and another condition which is known as Erdem-Chester disease. So keeping these differentials in mind, we did an ANCA estimation which was negative. AC was normal, CT chest was normal, and IgG4 levels was done. And we found that the IgG4 level was about 1.5 times the upper limit of the normal. The upper limit of normal for this lab was 2.0, which was way above 1.35. The upper limit for the lab is way above 1.35, which is the one that is in the guideline. And this patient had 3.14 gram per deciliter, or 314 milligram per 1.5 gram per liter, or 314 gram per milligram per deciliter. So we discussed with the urologist regarding a feasibility of an attempted biopsy. They felt that there was a lot of, we discussed with the interventional radiologist as well as the urologist. The interventional radiologist was not very keen because he would have to puncture close to aorta, and he felt that there is about 5 to 10% risk of puncturing one of the major vessels. He was not comfortable going with that. The urologist was also not keen on a biopsy, and patient underwent a stenting. So at this point, we thought that patient has a typical manifestation which is suggestive of an IgG4 related disease, and he has high IgG4 levels, and we had reached a stalemate. So we would start to treat as an IgG4 related disease and start the patient on 30 milligram prednisolone with microfiltrate mofetil. And this is the outcome 3 months later. There still is some bilateral mild hydroureteronephrosis with smooth narrowing of the mid-segment of the aorta with medial displacement of the ureters. But we got the images reviewed by a radiologist who said, who gave us the feedback that there is a significant reduction in the soft tissue component in the aorta, indicating that the treatment has been successful. So are we justified in starting the treatment here? I would be perfectly happy to start the treatment after getting a biopsy, but at this time, as I mentioned, we were in a state where we could not go ahead without getting a biopsy was a no-go, and we were forced to start a treatment. So if you look at the revised comprehensive diagnostic criteria, you'll realize that this patient had a criteria 1 which was met, and a serological diagnosis, which is criteria 2 which was met. And this could be what can be taken as a possible diagnosis of IgG4 related disease as per the diagnostic criteria. A very close differential diagnosis that we need to consider, because subsequently also we have come across patients who had retroperitoneal fibrosis, elevated ESR, some of them not having an elevated IgG4 level. So this was one of the differentials which I found is a very condition which I found is a very close differential of IgG4 related disease presenting as retroperitoneal fibrosis, which we may miss. This is Erdheim-Chester disease, which is a rare non-Langerhans cell histiocytosis. It's a clonal myeloid disorder. The characteristic clinical feature here is presence of foamy histiocytes, CD68 positive, CD1A negative, S100 variable foamy histiocytes. And this condition, other than involving the retroperitoneum, can involve the orbit and cause orbital masses, but this can also involve other areas like long bones, which is typically not involved in IgG4 related disease. So it can infiltrate the long bone, leading to symmetric osteosclerosis. It can lead to diabetic insipidus by infiltrating the pituitary, and of course can cause retroperitoneal fibrosis and periaortic and perirenal infiltration. So there can be significant overlapping features between these two conditions. Retroperitoneal fibrosis or periaortitis may be there, oral, renal and cardiovascular involvement could be there. But as I mentioned, presence of bone pain, diabetes insipidus, poor steroid response, and presence of CD68 positive histiocytes rather than the typical IgG4 positive plasma cells would be a key differentiator. This is one of the images of, typical images of Erdheim-Chester disease, where if you see there is infiltration around the kidney, and in addition to that, this patient also has got storiform fibrosis in the imaging, in the histopathology, but what you can nicely see is the bone scan showing sclerotic lesion, infiltrative lesion in the both tibia. So now let me come to the third patient. This is a 20-year-old gentleman who presented with recurrent nasal polyposis since 2010. That is, at that time he was around 5 years of age. He had undergone multiple surgeries, FES, orbital decompression, for progressive bilateral orbital swelling. In fact, we counted about 7 procedures. His problem started in 2010 and he presented to us in 2022. He had undergone 7 procedures into the in and around the orbital area. And he also had a presence, he was detected to have subglottic stenosis in between. He had recurrent respiratory infection. But what was striking was that this patient was steroid responsive. And on clinically examining him, we found that he had this bilateral lower eyelid swelling, as was shown to you, proptosis, lipedema, partial ptosis, and the ophthalmologist had reported that this patient was having an active scleritis in the right eye during his first presentation. He also had significant lateral gaze restriction. Rest of the clinical examination was normal except for mild hepatomegaly. So basically we have a patient who has a lot of tumefactive lesions in and around the eye and the paranasal area, the orbit and the paranasal area. So this patient, we did a CT and MR of the orbit, which both showed enhancing bilateral orbital soft tissue lesions. Biopsy was done, in fact, 2 times before coming to us, which was reported as inflammatory lesion, but description was not actually suggestive of an IgG4 related disease. This first biopsy was around 2013 and second was around 2015. Just before coming to us, he had another biopsy which was done, which showed the inflammatory pseudotumor, plasma cell rich infiltrate and storiform fibrosis. His ESR was markedly elevated, CRP was normal, I missed to mention it here. ANA was positive, but only the non-significant DFS 70 pattern. ANCA was negative, AC was mildly elevated, and the surprising thing is that till the time this patient came to us, an IgG4, she did not have an IgG4 level. It was a straightforward pick. We did an IgG4 level and it came out to be elevated. So we diagnosed this patient as having an IgG4 related disease, plasma cell pseudotumor of the orbit and sinonasal region, subglottic stenosis. You know that vaginos is one of those conditions which cause subglottic stenosis along with probably relapsing polychondritis, and this is another condition which can also present with subglottic stenosis. Chronic, and this patient had a chronic relapsing steroid responsive condition, IgG4 related disease, and we started the patient on steroids with MMF and followed by rituximab. His lesions, he has been followed up in 3 years. His lesions have slowly come down. They have not returned to complete normalcy. Still the prominence is there, but significantly better than how it used to be. In fact, last year we had had a feeling that we developed cold feet, and we felt that maybe we are missing something, and we recommended him for another biopsy. This time also the biopsy has come out as having dense plasmacytic filtrate with IgG4 positive staining cells, confirming with the diagnosis. So when you look at the eye involvement in IgG4 related disease, you can have lacrimal gland involvement, extraocular muscles, trigeminal nerve, eyelid, isolated orbital masses may be there, diffuse orbital lesions may be there, perioptic nerve could be there, and scleritis. This is one condition again that you need to look for. When many of us have received consultation from ophthalmologic colleagues regarding presence of evaluation for systemic disease for scleritis, and this is one condition that we need to keep in mind when we have a refractory disease. And these are the different forms of ophthalmic management of IgG4 disease. The first one is actually prominence of the lacrimal glands. The second, the figure B shows enlargement of the supraorbital nerve and the infraorbital nerve. And the C shows that the left eye cone is bulged, and figure D shows infiltration to the superior rectus muscle, symmetrical infiltration to the superior rectus muscle, and E shows a diffuse bulge in the orbital area, and the last one shows the lacrimal enlargement, and I think lacrimal enlargement, yes. So to summarize, IgG4 related diseases are rare multisystem diseases, but we need to suspect in case of situations of tumor-like lesions or infiltrate lesions in areas which are prone to the disease affliction. And they closely mimic many other diseases like malignancy, sarcoidosis, etc. And elevate the IgG4 levels, biopsy, suggestive biopsy would be the key to making a final diagnosis. Thank you.
Thank you, Dr. Vishad. That was a great talk. So while audience are thinking of the questions, if I may ask, what type of, what is the gross pathology of this fibrosis? Is it vascular, friable? And apart from this mass sort of, pressure life effect, is there any systemic effect?
Yeah, generally the typical gross histology described is that they would have a white cut surface, and a slightly gritty cut surface would be the typical look of the gross pathology. Systemic symptoms are extremely rare unless they are due to compressing any of the vital organs, such as if the renal involvement is there, patient can present features of renal failure, or other than that, systemic symptoms like fever, weight loss should be very atypical for IgG4 disease, and we need to think of other alternatives.
IgG4 disease is a fibro-inflammatory disease.
Yes, sir.
Systemic sclerosis is another fibro-inflammatory disease.
Yes, sir.
So, are we following the footsteps of scleroderma therapy
sir, actually,
in IgG4 disease also?
Probably it is at the level of where the fibrosis and inflammation occurs that important. The time period is probably what matters here. I think scleroderma, there is inflammation first and then fibrosis. And in this, probably we are looking at a situation where there is both going on, very low grade inflammation and fibrosis going simultaneously.
And how useful will be the immunosuppressive therapy if the
immunosuppressive therapy, sir, actually large scale trials are missing, but azathioprine is useful, methotrexate, mycophenolate, mofetil, these are some of the medicines that we can try, and rituximab has been found to be very effective. Then of late there is a new trial in NEJM which had looked into, I think, one of the FC gamma receptor antibody or something like that, inebritinib.
Okay. Are there any questions from the floor, especially the postgraduates at the back? When I was listening to this talk, I was thinking of 2 or 3 patients where actually I failed to consider this diagnosis. So thank you once again, Dr. Vishad, for this wonderful deliberation. Thank you. We close this session. Thank you.
For thanking Dr. Vinod Ravindran and Dr. Binoy Chipal for chairing the session.